Welcome, everyone, to the Kidney Korner Podcast. I am your host, Craig Merritt. I am also the founder and executive director of the Get in Position Foundation, where our motto is make sure you get in position as it relates to your health. I'm so excited about this episode, bringing on a gentleman who we've been kind of playing phone tag, text tag, email tag. He has a lot of great, interesting information for us. He holds a doctorate of health administration. He's also a professor at MUSC College of Health Professions and Medicine. He is an ambassador of the United Network of Organ Sharing, or UNOS, member of the American Associate of Kidney Patients. He was the first altruistic living kidney donor. Wow. In South Carolina, while a physician assistant of South Carolina. He's also a co-founder and executive director of the South Carolina Transplant Foundation, where their mission is to promote access, education, and advocacy for organ transplant patients. Without further ado, ladies and gentlemen, help me welcome my friend, my buddy, Zachary Sutton. Zach, how are you, sir?
Thank you, Craig. I'm doing well. I appreciate it.
Awesome. Good to have you on the Kidney Korner Podcast. And we're going to get into some information for our viewers who are mostly kidney patients, transplant patients, dialysis patients. This is a big one for dialysis patients and those individuals who are seeking a kidney transplant. First and foremost, Zach, let's get into this thing I was reading in your bio about being a living donor while a physician assistant.
While a student. Yeah.
You was a student.
I was in PA school at MUSC. I came to MUSC to go to PA school, but I started doing research there. And the first day that I got there, I had stopped at the transplant program, popped in and, explained who I was. I was going to be going to PA school at MUSC the next year. I was working there that I wanted to see a transplant. My grandmother died on dialysis.
Oh, wow.
My mom has had kidney disease since I was a little kid. And I went and shadowed a transplant while at MUSC. And I wound up about a little bit over a year later donating my kidney. So,
wow.
Yeah, it kind of happened that way. But again, like I said, I'd had a family history. We had seen it kind of firsthand. And I had volunteered before for both Donate Life and then Life Point Incorporated, which it was our organ procurement organization in South Carolina. Mm-hmm. And so I was activated, I was motivated, and all it took was for me to see that transplant to push me down that path to be an organ donor. So
nice. So this whole kidney thing is really close, near and dear to your heart.
It is. Yeah. And like I said, I tell people all the time, the first time I went to a nephrologist with my mom was in 1993. So I've been involved with kidney disease pretty much my whole life.
So, wow, that's very interesting too, because, and that's good to know, because you have a passion for it. That passion drives you. It's the driving force from what I'm hearing.
Yeah. So, it's a story I don't often tell, but my recipient actually had a bad outcome. And I spent a number of years kind of with that imposter syndrome, feeling like
Yeah.
There are certain things that I shouldn't talk about. Because again, I've had a blessed life. I
Mhm.
mean, other than, my mom having kidney disease, for the most part, my life has been really, really blessed. But what it took was it took for me to see what happened to my recipient, to know from him firsthand what he went through. And so I do this now. I'll be honest. I do this not for me. I do this for him. And,
Mhm.
God bless him. He's passed, but,
Okay.
this is me speaking his voice through me. I don't like public speaking. I don't like getting up in front of large crowds. Um, but it's something that's needed. And I'll be honest, it's something right now, like, for example, you mentioned the South Carolina Transplant Foundation. We give financial assistance to patients who receive a kidney transplant in South Carolina. And we didn't have that before. And so again, I've been blessed to be able to do some of these things and to bring awareness to these issues. And you're absolutely right. The transplant evaluation process, right? That's the doorway.
Yes.
That's the doorway that patients get into transplant. And it can be scary. It can be intimidating. In many cases, right? I've always heard patients say this, that, when they meet me in person, they're not going to like me, or they're going to tell me no because of this or because of that. But this is essentially the most essential part to getting patients, whether they're chronic kidney disease, whether they're dialysis patients, getting them into the transplant center, kind of figuring out their history, what's going on with them, checking things with them, and then making sure that they're safe, they're appropriate for transplant. We can talk about some of those things that might make you non-appropriate for transplant. And then that they understand there's a component of education here, that they understand what they're kind of signing up for
Right.
long term.
Absolutely, absolutely. So, shout out to the recipient, to your recipient. Rest in peace. That's huge when you mention you're doing it for him. Um, but also pat yourself on the back. I want to give you your flowers too, Zach, for being willing, because that's another whole conversation that we will probably discuss on the Kidney Corner in the near future about being a donor. So
Yeah.
just get used to it, Zach. You're gonna be back, okay? we'll have you back about being a donor, because we don't talk enough about that as well. But you're right. We're here to discuss the evaluation process. And for myself, it's so much we got to get into. Um, the South Carolina Transplant Foundation. I myself, I am a part of the Georgia Transplant Foundation, which is very, very huge, and we'll get into that as well. But this this evaluation process, it is scary to a lot of dialysis patients, kidney patients who are in need of a transplant. And number one is it's a lack of knowledge, a lack of education. So for starters, and we'll just break it down all the way down to a elementary piece, right? Or stage where people can grab it. What is this evaluation process, and why do we have one?
So it's kind of twofold. Number one, we have criteria for transplant. And so, the estimated glomerular filtration rate, big word, EGFR, though, right? I always tell patients, know your numbers. You always want to know where your kidney function is. But we have the requirement that patients' EGFR has to be at or below 20 before they can be referred to transplant.
Mhm.
Now, again, that's a number that they created. It's a way, because there is a shortage, right? We've got not enough organs to go around. And that's kind of that criteria where a patient can be referred to transplant. Now, like I said, I work in a general nephrology practice now doing transplant, but a lot of times we'll refer a patient, let's say your EGFR is 21, and I've been talking to you about transplant, and you're like, I really want that transplant referral. A lot of times we'll refer a patient with an EGFR of 21, and the transplant center will reply back, we can't start the workup on this patient until that EGFR is 20. One of the things that I've done at my practice is that we're now seeing patients with the EGFR of 25 to 20, and we're actually starting some of these tests, and we'll talk about these tests as we go through, but there is kind of some homework, if you will. There's some general health stuff that we need to get updated before that evaluation. But the evaluation process actually begins with the referral. That's either electronic or paper. And that's your provider, the dialysis unit, the nephrologist, your primary care provider. Patients can also self-refer, but that's where the transplant center becomes aware of you. And usually in that document, there's information about your kidney disease, demographic information about who you are, your age. They usually ask for your body weight, your BMI. There's information about your health history. Usually they'll want like the last note from your provider. They'll want a copy of your labs, again, to confirm that your EGFR is below 20. So there's kind of a pre-evaluation that takes place. And some transplant programs, based off of this information, they may actually say no to a patient before they even physically see them or meet with them.
Wow.
So, for example, some programs have age requirements. They'll say that, 75 or below for deceased donor. Programs have BMI requirements. So aggressive programs may go up to a BMI of 40. Non-aggressive programs may be a little bit lower. And then as you get older, sometimes that BMI requirement, 65 plus, that BMI requirement may drop down to 35. And in many cases, some of these initial records, unfortunately, can rule patients out for transplant. Mm-hmm. And so, for example, one of the good examples that I see regularly is BMI. And I'll explain to my patients, hey, our transplant program here locally has a BMI requirement of 38, and their BMI is 40. And they're like, I've done everything in my power to lose weight. Just go ahead and refer me. And then, of course, right, we get told no because the BMI is too high. Yeah. And so there's some of that can be done before the referral. And that's one of the things, what we do at our practice, we actually include some of this as part of the dialysis education. We talk about transplant. And then we also talk about specific issues with our patients that might be an issue for transplant. So I had a patient not too long ago I was educating, and they had a stroke. Mm-hmm. And one of the things, right, they check your functional status or your ability to move. But one of the things I had recommended, the patient was considering, I guess insurance was going to pay for 12 weeks of physical therapy. And the patient was like, I'm done. I've done enough. I'm recovered enough. And I told him, I said, hey, if you've got this physical therapy for another 4 weeks, and we know that there's a transplant evaluation coming up in a month and a half, let's go ahead and finish out that physical therapy. Let's get you moving as good as possible after your stroke, so that when you do go for that in-person evaluation, you're going to be better prepared. You're going to have a better chance of success. And so we have a pre-transplant kind of pre-evaluation process that's usually the paperwork, the insurance information. And then we have that physical evaluation itself. And that evaluation, most centers, it's going to be a half to an all-day thing. It's going to be a long process.
Right. Wow. That's that's so interesting. And I didn't even know that. As far as, and I've been through like several evaluation processes and didn't know that there was like a process. And these are, Zach, would you say these are not all transplant facilities, but you would say the majority of transplant facilities have criterias?
They do. Yes, sir. Yeah.
Okay.
And
Wow.
again, just like with the shortage of organs, right? A transplant program can only do so many evaluations a month. And so those slots, they're mindful of those slots and kind of who they bring in for evaluation. Now some programs, right, they may still, even if they have something that might be an issue, they may still be willing to evaluate the patients. So like, for example, BMI, we focus on that BMI number, but some programs will actually measure, right, your waist, your hip circumference. They may do a body composition test to see how much of your weight is from fat, how much is from muscle, how much is from water. There are some programs where the surgeon, right, if they press on your belly, they see how big your belly is. That's the biggest issue, is the bigger the belly, the bigger the incision, the deeper they have to go. And I've seen programs where the surgeons will make that decision. So a BMI of 41, if some of those numbers check out, if the belly's not as big, if they don't think they're going to have as much risk, then maybe they approve that patient for a transplant. So yeah, it can vary greatly by transplant programs, but a lot of work is done up front so that, number one, the providers who are seeing that patient know who they're seeing. They have all the records they need, because in many cases, right, we need the records from your whole history. And
Right.
that's before we even get into things like cancer, history
Yeah.
of heart disease. We've got to have all those records, history of any type of infections, because you're going to be immunosuppressed after transplant. A history of infections and immunizations are important. So you can imagine, in many cases, there are people working behind the scenes to obtain records, to obtain imaging, to get all of these things together so that when you come, we've got not only you physically there, but we've got as much information about you as possible so that we're making the best decision for you. A lot of people kind of view that the transplant evaluation is like, we're trying to find reasons to say no. It's the complete opposite.
Right.
We're trying to find reasons to say
Say yeah.
yes, and we want to say yes safely. If you've got
Right.
something that's not going to be safe, we're going to get you to somebody else. Or you've got a heart issue, we're going to get you checked out by the heart doctor. And that's something that I think sometimes that when patients hear it framed that way, they feel much better about checking these boxes, getting these things checked out, because really, we're not just approving you for transplant now. In many cases, there's a wait. So when we say that Craig is good today, we're also saying next year, the year after, we're also looking ahead and thinking about how long you're going to have to wait for a kidney as well. So that's why all this information is needed. We're trying to make the best decision for you long term.
That's very good stuff, Zach. And what I'm hearing for all of our viewers and listeners, our audience out there who are seeking a kidney transplant, you have to know how intricate, first and foremost, that this procedure, number one, this procedure is very delicate, is very intricate. Understand this, and you talked about it. Some people may say, well, what my belly got to do with it? Because sometimes it's all new, right? To a person seeking a transplant. And I have a few questions from some people who are new to dialysis, and that too is frightening in itself. And being new to dialysis and so on and so forth. However, explain to our viewers and those who are new to this whole kidney thing. I crashed into dialysis. I just found out I have kidney disease and my kidneys are failing. I'm in stage 5, renal failure. Explain to them, because a lot of people did not know that receiving a transplant, where does the transplanted organ or kidney go? Because people know for right now, oh, my kidneys are back here in my back. So
Yeah.
they automatically think, oh, they're going to take out my bad kidney and put in my new one. Please break that down, and why doctors, look at that BMI. That BMI is a big deal. That's a big deal, right? And also why, now I know the reason why, but that abdomen and that belly, why do they look at that?
Yeah. So there's 3 real big things to kind of unpack there. Number one, you're talking about patients who are finding out they have kidney disease, they're on dialysis. I caution everybody with this. There is just information overload. You can imagine somebody just finding out they have a problem with their kidney. They're having to start dialysis, something to filter their blood, a machine outside of their body doing this for them. And in many cases, I'll be honest, talking about transplant at that time can be difficult. And sometimes what I tell patients is, hey, we can talk about transplant, but let's get you educated about kidney disease and dialysis first and foremost. And then we're going to start this transplant stuff, because now we're going to take an organ from somebody else. We're going to plug it into your body. You're going to be on immunosuppressant medic. So now we're making this horribly more complex. And in many cases, patients are starting dialysis and getting referred for transplant all at the same time. And so it can be very overwhelming and very, very scary. So number one, I recognize that in patients. I think as providers, we could do a better job in trying to space out some of this education. We don't want to lose time, but if a patient's already started on dialysis, their time actually goes back to when they started dialysis. So again, waiting 3 months may not be the end of the world if we're trying to work out dialysis and catheters and graft access and all of these other things that have to be done, getting their Medicare approved, getting, all these social things in order. And then we can go and refer to transplant. But generally, we refer as quickly as possible to transplant to try to get patients in as soon as possible. So number 2, you talked about where we put the kidney in. Yep, we put the kidney in the front. That's the easiest place. The kidneys are in the back. They're tucked underneath our ribs. The way they used to do transplant surgery, the way they used to do a living donor procedure, was that they actually took out 2 or 3 of the ribs. They took the kidney out from the back, and the donor was actually in the hospital for months, and the recipient usually got out within a couple of weeks.
Wow, now that's reversed.
Now we can take out the kidney laparoscopically from the front, and then the kidney goes in on the front. We typically leave your kidneys in unless there's a reason that they need to come out. Cancer, a mass, sometimes patients with polycystic kidney disease or really enlarged kidneys, sometimes people with chronic infections or chronic urinary issues, their kidneys may have to come out for other reasons, but a majority of patients, their kidneys will stay in. That kidney goes in the front because everything that we need lives there. We have the bladder. We have vessels going down the leg that feed the new kidney. And it's a great location. It's tucked into the abdominal cavity. They create a little pocket. They put that kidney either in on the left or the right side, depending on your anatomy. And that kidney does just fine there in the front. Leave your native kidneys in. When we talk about that abdomen, it's not just the size of the abdomen, but if you want to talk about the size, in surgery, we have a term that if you want to go deep, you have to go wide. So if we do have a big abdomen, we have to make an even wider incision to go deeper below the skin. And the bigger the incision, the greater the risk you're going to have after surgery, healing it, and then getting an infection because of immunosuppression. The second component to BMI specifically is that we do have some research that shows that patients of higher BMI tend to not do as well with anesthesia. Now, I will say this, there's some conflicting research. There's some research that shows it's not an issue. There's some research that shows it's more of an issue. Either way, these are issues that persist across all surgery. So I used to work in orthopedics, and we didn't like to do BMIs on patients with a BMI of over 40. And of course, our thing was, number one, it was going to be harder for them to heal. It's going to be a bigger incision. It's going to be a harder recovery. And then our default answer was anesthesia doesn't like to put people to sleep with a BMI over 40. And so there are some anesthesia issues. When you're a larger person, you require more anesthesia to get you to sleep the way they need you to sleep for this procedure. And again, I don't work in anesthesia, but my understanding is that both that requirement to put you to sleep and keep you asleep can make any surgery more dangerous for you.
Wow. Let me just stop you 1 second, Zach. If you could imagine my face right now, the blow your mind emoji, that's what just happened.
Yeah.
That's what has happened, because when I say we, I'm saying I still consider individuals that are on dialysis, kidney patients, my brothers and my sisters. We're still in this fight. Just because I am a kidney transplant recipient, I still have kidney disease. And so I hope you all caught that of what Zach really said. I understand that you don't like your current situation. Dialysis is just is depressed. It's getting on your nerves. I was there, and you wanted a change. However, you guys have to consider what all goes into these decisions and why that transplant team or that evaluation committee or team, that department are requiring you to do XYZ. Anesthesia? Listen, folks, that's a serious thing. Putting you to sleep, like we're forcing you to go to sleep medically, and you got to think about it. And I really want our audience to really understand that. It's not just a so what type of thing. Yeah, they're supposed to put you to sleep. Listen, I met an anesthesiologist years ago, Zach, when I lived in Richmond, Virginia. And we joked about, I was asking her about why do you wanted to go into it. She said, and do you enjoy it? She said, Craig, putting people to sleep is easy. That's the easy part. She said it's waking them up.
No. Yeah.
So I just wanted to put that out there. So individuals can have a different perspective, right? Because it's got to be your perspective. And we could understand why all of these requirements, why do I have to lose more weight? Why is it so vital? Well, first of all, it's vital to your life and for your health. Number one. And 9 times out of 10, and I'm speaking from a cultural perspective, 9 times out of 10, we have individuals who are diabetic, right? Individuals who have high blood pressure, hypertension, and we're obese, we're overweight. So we need to get that down anyway. But I mean, I heard you about the incision piece, but what really got me, Zach, was that anesthesia piece.
Yeah.
That right there should make people stop and say, "Hey, okay, I get it."
And we do have some promising things on the horizon. So,
Okay.
for example, one of my physicians that was at MUSC, Dr. Satish Nadig, he went to Northwestern, and his team actually did the first awake kidney transplant, where they used a spinal block. The patient was awake during the surgery, and they were able to do a kidney transplant that way. The other thing that we're seeing more of, that we've been doing laparoscopic and robotic nephrectomies, taking kidneys from living donors.
I've had
but now they're doing robotic kidney donations for the patient, which is smaller incisions, less anesthesia, don't have to do the big incision. And so some people think that either the combination of one or both of these, whether patients are more awake or the robotic surgery, may allow us to take a little more risk on higher BMI patients in the future. I think it's going to take some time. It's going to take some research before programs feel more comfortable with that. Yeah. But that's where we're headed. I think that's where we're headed with that. And then we've got these GLP-1s, these new drugs that can help patients lose weight. And in many cases, if it's 20 to 30 pounds, that's something that in many cases, we can do pretty easily. And then if we can keep that weight off, like what you were saying, it won't just benefit you before transplant. It's going to benefit you with the new kidney too, after transplant. Yeah. Make your diabetes better. If you don't have diabetes, it may help to prevent or reverse pre-diabetes or, before you get to diabetes. So yeah, it can have a huge, huge benefit losing that weight before transplant.
Oh, absolutely. Absolutely. Wow. When was that surgery done? How long ago that was done? We're about the awake.
That was about a year ago. Yeah, it was a little bit over a year ago at Northwestern.
Oh, wow. Okay. Me personally, I'm gonna need a little bit more time with that one. I need some more of those to happen. And to your point, let's look at the study. Let's look at the data.
Well, we already do a lot of that in like orthopedics. A lot of our total knees now, the patient's not completely asleep. Right. And it makes it a lot safer. And again, the reason why we went to that in orthopedics was a lot of our patients who get total knee joints tend to be older and already at a higher risk. You're putting a 70 or in some cases an 80-year-old to sleep. It's a lot easier if we can get away with this kind of quasi in between. They do a spinal, the patient doesn't feel anything. So yeah, that's going to be big. That's going to be big for the future.
That is going to be big. Thanks for mentioning that. Wow. Because what you're saying is there will be options.
Yep.
There will be options for the patient. Wow. Okay. Wow. Okay. So my next question is what goes into these deciding committees that someone is a good candidate for
Yeah.
transplant?
So let's, before we get to that, let's talk about the evaluation. On the day of the evaluation, you
Okay.
meet with the social worker, you
Yeah.
meet with the nephrologist who's
Mhm.
focused more on kind of your medical history, your kidney disease. How could that affect your transplant later on? You meet with the surgeon, right? The one who's going to be doing the surgery. And then you'll also meet with the dietitian.
Mhm.
And so that's how we're kind of evaluating you. From a social worker standpoint, we look at things like insurance. Most patients have to save funds pre-transplant. We have to look at things like drug coverage after transplant, both for things like immunosuppressants as well as medications that you might be given during the surgery.
Mhm.
They look at things like social determinants of health. So, like for example, I listened to a podcast recently from NKF, and they were talking about how transportation keeps a lot of patients from transplant, whether it's
Yeah, wow.
issues getting to
Yeah.
evaluation or
Yeah.
even after transplant, getting back and forth to get labs done, office visits done. So we look at all those kind of social factors that go into you, and we look for any barriers that might affect transplant.
Mhm.
And that's things also like compliance. You're right. Do you take your medicines regularly? Do you go to dialysis regularly? Do you miss office visits? Because again, some of these things might affect us post transplant. The nephrologists, they're going to look, and again, I know you're going to have Dr. Salas on here. She's
Yeah.
amazing. They
Yes.
look at that medical history. So what are the things about you that got you to kidney disease? What are the aspects of your kidney disease? What are the aspects of your dialysis that could challenge us either during your transplant or after your transplant? And so a lot of these issues need to be taken into account. Do
Mhm.
you have diabetes? Is it well controlled? Are you on the right medicine? Is your blood pressure too high or too low? Do you have heart issues? Do you have a history of cancer? All these components, that's what the nephrology team is looking at. The surgery team, just like we said, they're going to look at the CT scan of you. They're going to look at your belly. They're going to look to see if you've had any other surgeries,
Mhm.
cardiac surgeries, vascular surgeries that could affect the vessels. Do you have you had any surgeries in the belly that could cause scar tissue? All of these are things that contribute from the surgery standpoint of whether or not you would be a good candidate. And then that final, the dietitian does more education, but then also is looking at things like BMI, looking at things like nutritional needs. Are you low protein before transplant? Are you diabetic? So again, some of these nutritional issues that are going to be important post transplant.
Right.
And then all of these components from this evaluation are brought together in a committee. And our committee is it's kind of the way to think of it is we talk about patients without mentioning their names. And the
Mm.
reason why we do that is we try to avoid any bias, right? I don't, if we're talking about my favorite patient, right, there'll be a part of me that's going to be like, no, I know this guy. Let's give
Let's
him a
go ahead and
break.
do it.
Exactly. So we bring everybody up, right? For me, right? I'd be a 45-year-old. I would be, they wouldn't say my name. They would just bring me up medically, socially, surgically,
Right.
dietitian. All of these issues would just come up. We discuss these issues as a group. Now, for some of these issues, you may have heard this term before about a contraindication, right? Something we shouldn't do. There are
Mm.
some that are absolute. So, like for example, BMI programs will have a BMI cutoff of 40. That is absolute. You can't change it. However, we do have some relative contraindications. So, let's say, for example, compliance is a good one. let's say that we've got the dialysis run sheets and a patient's missed every Friday dialysis for the last 2 months. Well, the social worker is going to talk to you. They're going to ask you these questions. The patient has a new job and he's got to go to work on Fridays.
Right.
We're not going to punish somebody for taking care of their family, right? For doing what they're supposed to be doing. So again, this is something that we can take into account. We can discuss, we can talk about. And if that's a relative contraindication, that's something we can overcome, right? We can write a letter to the dialysis unit or the nephrologist and say, hey, can we work on this guy's schedule so that we make sure that he's getting enough dialysis during the week, he's being kept safe, and then we don't have to worry about him missing on Fridays because now he has work on Fridays. So, right, maybe it might be something simple that they need to change to a Tuesday, Thursday, Saturday schedule.
Right.
So then 2 days a week, they're able to work. And then that third day, it's on a Saturday, they don't have to work. And in many cases, some of these things we either need more information about. So we might have to go see a specialist, or we might have to, right, make that change and have him start showing up more regularly for dialysis. Some things, it might wind up being a no because of that issue. But again, we have these absolute contraindications, and then we have relative contraindications where we have a little bit of leadway in there that maybe if we get a little more information, we get a plan in place, we can address that issue without it keeping the patient from transplant.
My name is Joshua Albright.
I'm Kimberly Queen, and you're watching the Kidney Korner Podcast.
All right. So Zach, you mentioned something, and I really want my audience, especially those who are on dialysis seeking a kidney transplant, some of the things that are vital and very important to their evaluation process is being compliant. When I was in dialysis, there were so many of individuals I saw just getting off the machine, cutting their treatment short. And please understand, people, that machine is not just cleaning and filtering your blood, removing waste. It's also collecting data. That machine is collecting data. It knows when you come off early. It's a computer as well. It's a computer as well. It's keeping track of your run time. Every time the machine was paused, every time your blood pressure dropped or went up, it's keeping track of how long you actually stay on your treatment time. So those are the things that these evaluation committees, they look at, because you think dialysis, and I'm saying this from a lived experience, you think dialysis is something, wait till you get to the other side. Transplant, I'll take a transplant any day in dialysis, any day. However, it's more work on the other side of transplant to maintain that organ, to keep that organ, to prevent that organ from being compromised, because our bodies are beautiful. God did a thing when he made us. And because we're still studying it, we're still figuring out things about our anatomy. And it knows, that's why we're on these immunosuppressant medications, because the body know, hey, something foreign in here, right? Something is foreign in here, and we got to get it out. Even though we need it, The body does what it's supposed to do. So that's the hard part, keeping it. And I say all of that just to, I'm not trying to deter anyone from getting on the transplant list or being evaluated. I just want you, because for me, it was a mental thing. Do you see that a lot with the patients that you help and assist to prepare for transplant? The mental piece of this whole evaluation process. Let's talk about that before we get into some other things.
Yeah. Oh yeah, definitely. And that will keep somebody, people will stay with what they know. That's always the easiest. So when you start talking about, well, you're going to have to travel to a transplant center, you're going to have to get a scan, you might have to get a heart test, you might have to do this, do that. You can see how that quickly, oh, wait a second, I don't know about all this. I was thinking it was going to be like a doctor's appointment. I didn't know I was going to have to get a colonoscopy and a heart cath. And, it becomes a lot more multifaceted. But, 2 points of what you just said, number one, in many cases, right, patients have a reason why they miss dialysis sometimes. Mm-hmm. Sometimes they don't. Sometimes they just want off early. Sometimes they don't feel well. But in many cases, if you just come off and you don't document that reason, you don't let that tech know that your blood pressure was bottoming out, you don't document to the provider, they're not going to change your dialysis prescription. The blood pressure is not going to get addressed, and you're going to continue to have that issue. Or like the gentleman with the job, if you're not able to articulate that, nobody's able to help you or to kind of work around things or to come up with a way to fix it. So that's number one. Number one, ask for help. There is help available. There are things that we can do to address things to help you with compliance, keep you safe, and get you to transplant. There are some people, though, that just don't have excuses. And I see this a lot where, I don't know why I did it. I didn't want to come to dialysis. I wanted to do my own thing. Well, number one, thank goodness that you're safe. Thank goodness that nothing bad happened. Mm-hmm. But we forgive. We don't forget, but we do forgive. And so most transplant centers, right, they might say, we want 3 months of compliance, or we want 6 months of you getting back on the machine regularly. And in many cases, you can overcome that. So don't think that's the end of the world. Compliance is something you might be starting day one, but hey, let's start today, day one. The issues that you have that require you to get off early, your transportation, your blood pressure, you've got other things, you've got a part-time job. Hey, let's get that to the social worker. Let's get that to the nephrology provider. Let's get that to the charge nurse. Let's see what we can do to address those issues. Mm-hmm. And then we can come back from them. The second thing I'll bring up, Craig, you mentioned not being at dialysis and not being on the machine. You also miss other things at dialysis, right? You miss labs if you don't get your monthly labs. Mm. You miss things like your medications, right? Some of our patients get their medications at the dialysis unit.
This is true.
The social worker might be following up with you about that transplant appointment. You're not there. You miss the only day of the month that the dietitian is there.
Yeah.
So again, there are other aspects to dialysis. Dialysis is kind of like your medical home or your primary care provider.
It becomes that. It becomes that.
Exactly. Yeah. Mm-hmm. Yeah. And so by you being there, there are also things that are being coordinated, mm-hmm. being monitored. You have access issues. We don't know that unless we're looking at your access. We're checking your access. You have volume issues. You're swelling. I see that happen a lot to patients where they might need extra dialysis, but because they're swollen, they don't feel well. They're like, well, I'm not going to go to dialysis today. And now it makes things even worse. We wind up with a hospitalization. We wind up having to take more fluid off. And that could have been avoided had we, again, gotten there. And again, I know it's hard. It is not easy. Yeah.
So folks, listen, to all of my dialysis patients out there, whether you're doing it at home, if you're going into the center, please, it's to what Zach stated, it's vital. Your life depends upon it. Please understand that. I know you don't feel like it. I've been there. I'm speaking from experience, folks. You don't feel well. You despise it. I'm talking about what I felt. I despised going, but I went because my life depended upon it and I wanted to get to the other side. Once I understood what was involved and what was looked at, what could have been counted against me, I had to push through, folks. I had to push through. Please, whatever you do, I know you're tired. I know you're sick of it, right? I know sometimes that technician is getting on your nerves because that could be it too. that could be it too. I can't. Hey, Zach, I think I told you we're on the corner, the Kidney Korner, man. So no holds barred. We talk about it all here, and sometimes that's a feeling. But I'm saying to you all, get over it. Please get over it because your life depends upon it, right? There are some better options. We talk about better options, right, Zach? Better options, a better way of life. Dialysis takes up too much of your time. And you got stuff to do. I wanted to say something else, but you got stuff to do, folks. The transplant
live longer, better life,
yes,
less dietary restrictions, able to travel.
Yes.
I mean, it checks so many boxes for you. It's amazing. But again, you know, not everybody qualifies. There are certain things that keep some people from transplant, and it does so appropriately. But if you haven't gotten that answer yet, if you haven't been evaluated, if you haven't been told no, it is definitely something to seek out, to learn about, and to try to get through this process.
Yes. Thank you for that. Now, Zach, you and I, we were chatting or messaging each other on LinkedIn because I was seeking after a dental hygienist, right? And I want you to talk to this piece because many people don't think or know how important it is for these other things, because there may be some other request required of us. When I say us, I'm saying dialysis patients, those who are seeking a kidney transplant, to make sure we go get checked out. Some people may say, well, why going to a dentist got to do, what does that have to do with me getting a transplant? You know, how do those two things correlate? Well, I'll tell you, it's a domino effect if you don't get it done. So talk about that piece.
Oral health affects your whole body. I mean, there's just no other way around it. You know, our mouths, number one, that's where we put in a majority of our food. That's where we put in all of our pills, all of our medications. And so really oral health is kind of that entryway, right? Whether we're talking about taking immunosuppressants after transplant, or we're talking about taking blood pressure medicines before transplant. Our mouth is the start of that. With that, we can get into things like issues with our teeth, issues with our gums, ulcers, wounds, and the mouth is very vascular, right? I have a Great Dane puppy who recently hit me underneath the chin and chipped my teeth. but I cut my gum, and my gums bled for like a day and a half.
Wow.
Our mouth is very, very vascular. So you can imagine if you have infection in your mouth, it's real easy for it to get into your bloodstream. And so pre-transplant, anybody with any open wounds or sores, any really bad teeth or infected teeth, those are going to have to probably get pulled, because you're going to be immunosuppressed after transplant. And it's real easy for that infection to get into your blood and to make you septic.
Wow. That's very important to this process, and also being very successful at becoming a good candidate at evaluation. Wow, that dental piece, folks. For one, I may speak for the majority of the listeners out there. I can't stand going to the dentist. I do not like going to the dentist at all. But I had it all done: root canal, a wisdom teeth pulled. When you talked about anesthesia, that's where my mind went to. Was when my teeth were pulled, my wisdom teeth were pulled. I had a tooth that just was infected. It rotted out, and it was and I had to take care of it. I had to get it taken care of prior to the whole evaluation process. So that's a great point that we need to think about when we're seeking a transplant. That it's not just about getting the transplant, but it's maintaining and keeping the transplant, folks. You don't want to go back. You do not want to go back, and understand when we're told you're going to be on these medications for the rest of your life. It sounds like a bummer, right? It sounds like, however, it's keeping you alive. It's keeping you alive. And also, you have to understand there's certain things that you will be restricted from post-transplant. Let's talk about that, Zach. The post-transplant process afterwards. I know that there are dietary restrictions while on dialysis, while in kidney failure. Are there, and there was a question. We're going to get into some of these questions from our followers and subscribers from TikTok and YouTube. One of the questions was, after transplant, will I have dietary restrictions?
So, number one, there are fewer dietary restrictions after transplant than there are pre-transplant. I will say this: there are some dietary restrictions that may continue. So, for example, patients that may be on an ACE inhibitor, angioretention blocker, mineral corticoid receptor agonist. It's a heart medicine, it's potassium sparing diuretic. There are certain medications that may continue after transplant that could affect like your potassium. So sometimes those potassium things continue, but it's not because of the transplant. It's because of some of those medications. There are issues with things like grapefruit, marijuana, CBD can interact with tacrolimus. There's a specific pathway. So one of our main immunosuppressants, not every patient's on that medicine, but I would say most are.
Yes.
There is a pathway that we have to watch for, because if we block that pathway with another medicine, then that medicine can build up at higher levels in your blood. Some patients might have a risk of diabetes post-transplant.
Yes.
So while you can go back to eating whatever you want, we do talk about moderation, especially that first year. Patients have what's called the transplant honeymoon, is what I call it. It's like being married. You get transplanted, life goes back to normal. Those dietary restrictions go away. And I'll be honest, most patients, they'll tend to gain some weight after transplant because they're feeling good. They're eating good. They're doing more. Yeah, exactly. And it's like being married. It's like the honeymoon. You get home from the honeymoon, you got 3 meals a day. You got wedding cake in the fridge. You're just eating everything.
Yeah.
And so in that regard, less restrictions. There are some things that we watch. Sometimes that's because of medications. Sometimes that might be because of risk of diabetes, right? Just because you got transplanted doesn't mean you can eat a bunch of sugar and carbohydrates.
Right.
But a lot of things get better. And most patients, after the initial hospitalization, they don't have to follow up with the dietitian long-term, right? We may have them supplement some things, maybe some magnesium, right? Patients may still require some iron, some oral iron if they're a little anemic. But in many cases, the dietary restrictions are much, much less than what they were on dialysis. And I think that's one of the things that really kind of blows the patient's mind, because I had to watch phosphorus so much. I couldn't eat this. I couldn't eat my favorite food. I couldn't have a dark soda. But again, a lot of those things can come back. Now, one of the things that I always remind patients, let's say that we were eating unhealthy before things tightened down when you were on dialysis. I don't necessarily recommend that you go back to eating unhealthy all the time.
Right.
As a kid, I grew up, right. We ate fast food. We ate Vienna sausage. We ate, all the things that as an adult, you probably shouldn't eat.
Right.
But at the end of the day, it's not the end of the world if you eat unhealthy a few times a week. What we don't want is, we don't want you to get back into the trap of eating unhealthy all the time. And that, whether you're transplanted or not, that's something that we don't talk about enough, about how food affects our health. But I'm a big believer that food is medicine. And of course, food's expensive, especially healthy foods, fresh foods. But any of this education that you've learned on dialysis, some of this is going to still serve you well, even though the restrictions go away, right? You shouldn't eat too much of anything. Right. So like tomatoes, my dad grows tomatoes in the garden. He'll eat a tomato sandwich every day for a month. And, everything in moderation, right? Everything
that
in
potassium
moderation.
Level is crazy.
Oh, yeah. Yeah.
That's awesome. So we're going to take some questions, Zach, from a few individuals from TikTok. This is from Marceau on TikTok. She's new to dialysis, and they want to know, she has to report into her transplant facility to do blood work or do classes. She also wants to know if this has to be done every month, being that they've told her like her wait time to receive a transplant is 3 to 5 years.
So a lot of times the blood work does have to be done regularly. Those HLA labs that are drawn, usually they're drawn at dialysis. You don't have to actually go back to the transplant center. The dialysis center will draw them and send it to the transplant center for you. Now, education classes, different programs will have different things. Usually you get your education at evaluation. At reevaluation, that's usually either every year, every 18 months, depending on kind of the program and what they set for you. You do check back in with the transplant program, but that's a much shortened visit with less education. I do know that there are transplant centers now So for example, I have a couple friends that work at a transplant center in Georgia, and they're asking patients every year to watch the transplant video again. And that's just so you had that education. Let's say you were evaluated in 2019 initially.
Mm-hmm.
That's 7 years, right? That's 7 years. All we've seen you for is a re-eval visit. Has anything changed? Anything new come up? Any new surgeries? Not necessarily getting education. So it's not a bad idea to put education in there. But again, different programs have different requirements. But your dialysis unit should handle the blood work.
Right.
And then education or reevaluation, that would be set at the time you're listed so that you'll know, hey, I'm going to be seen annually, or I'm going to be seen every 18 months, and I've got to do all the things they ask me to do.
Yeah. So just in summary on that question, which I'm glad you brought up and mentioned, and this is for every dialysis patient who's actually going into the center, even if you're doing a dialysis at home, your dialysis center, if you're on a transplant list, your dialysis center should be taking your transplant labs. They should be pulling and drawing your transplant labs, folks. If you have been approved to get on a transplant list at whatever facility it is, your dialysis center should be drawing your transplant labs. If they are not, you should be inquiring and asking why. This is also about self-advocacy as well.
And remember, these labs are important because it's a HLA, human leukocyte antigen, big word, but it's essentially an antibody screen. And so they're going to use these most recent labs to compare you to the organ when it comes in. And that's why we want to make sure that nothing's changed. We've got to get you the right organ that you match with. And that's why this monthly blood work is so important, because sometimes it can change. It can change if you've had a blood transfusion. It can change if accidental needle stick, maybe nobody knew about. It can change just based off of the lab work, but it gives us the best shot of getting you the best kidney that you're going to match for at the time of transplant.
Absolutely. Glad you mentioned it again. Every month, folks. It's not every so often. Please don't get it twisted. Every month, you should be looking forward to getting your transplant labs drawn. I was a stickler, Zach, because every month they do lab work, right? Mm-hmm. Those centers do lab work. And I would question my technician, where's my transplant lab vials?
Yeah, you want to see them.
You got them?
Yeah.
I said it should be 3 of them because I'm on 3 lists. And folks, you have to keep track of your business. Mm-hmm. This is the business.
I was going to say that's how dialysis units keep track of who's listed. Is those blood vials. Yeah, that's an easy way for them to know who's listed.
Exactly. But the most important person who needs to know is you, the patient. Zach, I'll just break. I didn't care who else knew. As long as I knew and you had them. Because if you don't have them, that's a problem. If you I know I'm listed on 3 transplant lists. If I see you come back with 2, we got a problem, folks. We got a problem. Go back in the room and look underneath the shelf and see if you see the 3rd. Because if you don't see the 3rd, now I got to call that facility to say, hey, what's going on? Did you guys send my tubes? You got to keep track of it, folks. Because why? Your life depends upon it. All right. So we have another question from a TikToker, MD Naj. If you are a diabetic, can you apply for a kidney transplant?
Yes, you can. I would say, diabetes and hypertension are our number 1 and number 2 cause of kidney disease. So actually, most of our patients who get transplanted with a kidney transplant will have diabetes. Yep. So the things we look for there is, number 1, we want your diabetes to be well controlled. We shoot for that perfect A1C below 7. But again, if your A1C is in the single digits and you've been working on it, that wouldn't disqualify you for transplant. Now, if your A1C is in the double digits, right, you're a much higher risk for complications from diabetes, things like diabetic ketoacidosis, or your diabetes, your blood sugar getting too high. So yeah, we might ask for better control. So in patients that don't have good control, right, maybe seeing an endocrinologist. At MUSC, sometimes we would actually ask patients to see our endocrinologist, because not all endocrinologists, kind of use the same kind of protocols, if you will. So yeah, we want that under better control. There are some patients who are diabetic who might qualify for a kidney pancreas. So pancreas transplants are typically type 1 diabetes, but we also get some patients that might be type 2 diabetes, lower BMI, who could benefit from a pancreas. A lot of times they'll actually talk to you about that if you meet some of those criteria at the evaluation. And then a kidney pancreas transplant, believe it or not, it can happen a little bit quicker because we try to keep organs together. So if you're listed for a kidney pancreas and we get a pancreas and a kidney from a donor, that transplant would go to you, because the list of people who qualify for a kidney pancreas are much smaller than the list of people who would qualify otherwise for a kidney alone.
Awesome. And so folks, the transplant facility Zach and I are referring to, and you talked about earlier being biased. Zach, I'm gonna just tell you, man, I'm biased to MUSC. I'm just biased to MUSC in Charleston. I always have you guys with me. My transplant facility, folks, you gotta love it. One of the greatest, in my opinion, because of the way you guys, post-transplant and the treatment that I received, my wife and I received, I tell you, I wouldn't have it no other way. I really appreciate those guys and the transplant team at MUSC. Some more questions, Zach, some more questions.
Okay.
This is from actually one of my mentees of the Get in Position Foundation, Marvina, who is actually in South Carolina. She's a resident of South Carolina, and we need to figure out how to get Marvina part of the South Carolina Transplant Foundation and what she needs to do. But Marvina asked, once transplanted, will my numbers start going down immediately, or will it take time?
Generally, for a majority of patients, those numbers are going to go down immediately. Okay. We can have a complication called delay graft function, DGF, or sleepy kidney. And essentially, that is where the kidney is a little bit slower in waking up. It's rare, but it can happen. And some of those patients may actually require a little bit of dialysis while that kidney wakes up. You can imagine, just like the surgery is big for you, everything that happened to the donor from when the donor died to the kidney coming out of the donor, being placed on ice, being brought to the transplant center, and then the kidney's also going through the same surgery you're going through.
Right.
That can affect that kidney. And But no, for a majority of patients, that kidney's going to start working right away. That kidney's going to start to improve. And you're going to be making urine pretty much at the time of transplant. Like I said, a smaller portion of patients can get that sleepy kidney, but a majority of them, almost all of them, do wake up and do perform well.
Awesome. One last final question from Marvina, because she's one of my mentees, and we discussed, because she asked me this question. I believe she has a friend who was on dialysis, and they were taken off of dialysis. I have no idea. They don't know why. From your experience and knowledge, what are some of the reasons why a person could be taken off of dialysis?
Their kidney function improves. That's generally the reason. So in the United States, right, we qualify for Medicare if we wind up requiring dialysis long term. Sometimes, of course, you can imagine most of us, as we see our numbers, they're declining, and eventually we wind up on dialysis. Usually, for a majority of patients, their kidneys aren't going to recover. For some people, though, right, their injury may have been more acute, where their kidneys just tanked. They wound up on dialysis. And then over time, that dialysis gives some relief because it does the work of the kidneys. They may actually recover some kidney function and get back off dialysis.
Okay.
That's rare, but that can happen. And I've seen that where patients may need dialysis just for a couple of weeks. Patients may need dialysis for a couple of years. I've seen patients, after a year or two be able to come off of dialysis. But in many cases, they're still going to have kidney disease. They're not completely cured. They're usually going to be chronic kidney disease, stage 4 or stage 5. Because again, if the kidneys were going to recover acutely, that would have happened just after a couple of weeks of dialysis.
Okay.
But yeah, there are patients who can recover. That's rare. And when we sign that form stating that the 2728, the form that is going to essentially get you approved for Medicare on dialysis, the nephrologist is stating, they've been on dialysis for 4 weeks. We do not think their kidneys are going to recover.
Okay.
And so for a majority of patients, right, they're not going to get that opportunity to come off the dialysis unless they get blessed with the transplant.
Nice. All right, Zach. So as we wrap things up here on the Kidney Korner podcast, talk more about your foundation.
Yes. So again, we're modeled after the Georgia Transplant Foundation. It's no secret. There were 3 of us: Dr. Carlos Zayas, who is now the medical director of the Prisma Transplant Program in Greenville; Samika Berry, who is a transplant social worker at Medical University of South Carolina, Lancaster; and myself. I used to work for MUSC in outreach. Now I lead a transplant program in Carolina nephrology in the upstate of South Carolina. But the 3 of us, essentially, our patients within the first year of transplant had no assistance. You can apply for things like the National Kidney Fund. Usually they run out of money during the year. We did have financial assistance at MUSC, but you had to go through hoops, and not everybody qualified for it. And there wasn't necessarily a huge fund that everybody could get assistance.
Mm-hmm.
And then at MUSC, our requirement was we wanted patients to save $1,000, right, pre-transplant, that they had in their pocket to help them. So we came up with this idea. We can't do what Georgia does because they're too good at it. They've been doing it too long. But what could we do to financially assist patients in South Carolina? So what we did, we formed a nonprofit. We started to collect funds on behalf of kidney patients. And right now we give $200 out of the gate for any patient who's from South Carolina and gets transplanted within the first year. We are adding additional assistance to that. So it's going to be in the future $200. and then we can add 200 again with a increased medical need. And then the other thing that we're adding is we are adding liver. So we're now starting to add other organs to that assistance. But no, we didn't do anything special. We just copied what was already done. And we understand that $200 isn't a lot. The reason why we came up with that number was, number one, it's really easy to get, right? As a patient, you could attest to this. Within your first couple of days, right, you spend a couple of $100 out of that savings account right away.
Yeah.
So it's a low number, but we can get it to you either in a check or a Zelle within 72 hours. And so we essentially just top you off right out the gate. And then now in the future, we're going to have, if you have additional financial needs in that first year, we can come back and do another $200. Your transplant social workers should also be looking at other assistance, like the National Kidney Fund. If the hospital has any assistance, those assistance programs take a little bit longer. You have to fill out financial documents. You've got to submit things like how much money you make, all that jazz. Ours is a quick one-page form. Your transplant social worker will send it to us, and we'll get you a check within generally 72 hours.
Okay, that's great. That's great. So does the South Carolina Transplant Foundation, and I know that you guys are trying to model after Georgia GTF, but GTF allows individuals to raise their own funds, and they match up to $10,000. Now I know South Carolina is unable to match up to $10,000, but do you provide those types of accounts where individuals can raise their funds and they're protected? Protected, when I say protected, meaning that it's not counted as income, so it's not taxable.
Yeah, we don't have that yet. So we have been talking about having a way to help promote patients. So for example, like on our Facebook page, I think we have about 90 people who follow us. We have talked about ways to kind of amplify patients, either asking for a kidney, looking for donors, things like that, maybe having a way that the foundation can do that. But no, we're 3 years out. We're primarily focused on patient assistance. We would love that, to be able to do that and create patient-specific accounts. Our biggest issue is we don't have full-time staff. So it's still primarily the three of us that are answering emails from social workers that are cutting checks or sending out Zelles after hours, after work. In the future, we are looking at trying to find somebody to help us full-time. I think when that happens, we can start opening and kind of unlocking other components of this. And then here recently, I've been working with North Carolina. Initially, we were going to look at doing a North Carolina Transplant Foundation, but thankfully, Donate Life in North Carolina is now exploring ways of saving money and then giving reimbursement, kind of modeled after us, to North Carolina patients so that they could do the same thing. How do they get $200 in somebody's pocket within 72 hours? And that's what I'm working on with them right now, so that we have this great thing in Georgia. We've got some of it in South Carolina. We're going to try to add some of it in North Carolina. And then hopefully in the future, we can continue to expand this. But yeah, that would be a great idea, because people could donate to the 501 nonprofit. That account is held, it's set aside specifically for the person that they donate it to. And then we were able to do that. No, there's a couple of things we're looking at. I've had a couple of people approach me about donating cars. So I've been doing some work on figuring out. So let's say I did get a car donated. How do I handle that? How do I sell it? How do I auction it? How do I get money for patients? If we're going to give it to a patient, how do we handle that? Like, what work needs to be done on the car? I need to have a mechanic check it out, make sure it's safe. But again, Yeah, exactly.
Everything has a cost to it. So welcome to the executive director world of nonprofit organizations, folks. So
we're figuring it out, but we are here. Your transplant social worker, even if you're transplanted in Georgia, we do a lot of patients that are transplanted at Atrium, Augusta, Emory. Your transplant social worker can reach out, and the only requirement we have is you're from South Carolina. Yep.
Great. Awesome. That's awesome, because Marvina is definitely there in Hollywood, South Carolina, I believe.
Mm-hmm.
Yeah. So we'll be talking with you. So listen, Zach, I had a great time. I learned a lot today. In closing remarks, did you have anything else for our audience regarding evaluation?
Yeah, it's hope. You can't see it today. Just like Craig is telling you his experience, what he went through, how great things are now. You can't see it today, but coming in for an evaluation, listening to educational videos, listening to people who have been through this, you're going to get a glimpse of it. There is something better. You've just got to hang on to that hope. If you have hope and you can see this process through, we can check all the boxes. We can make sure that you're safe for transplant. There is something better than dialysis.
Awesome. Zach, thank you so much for being our very special guest. You broke a lot of things down for us, and hopefully you will not be a stranger. There's something else we need to talk about on another episode of the Kidney Korner Podcast. So we'll definitely have you back, buddy. I really appreciate your time. I will put you backstage. Just hang out for just a second, and I'll be right back with you. Hey, folks, I had a great time. I don't know about you, but I learned even more about evaluation. I thought I knew because of my experience with transplant evaluation, but hey, I didn't know the half, to be honest with you. So again, make sure you share this link with someone else who needs to hear it, who needs to learn and know a little bit more about the transplant evaluation process. You guys, please subscribe to our YouTube channel at getinposition21.org. Visit our website. It's been scrolling at the bottom of the screen. Those of you who are listening on the Apple Podcast app, our website is www.getinposition21.org. You guys can also reach out to us, contact us, connect with us by emailing us at info@getinposition21.org. And as always, folks, make sure you get in position as it relates to your health. We see you guys soon. Take care.